Alright, so neurology, next part. Um, Important topic of cerebrovascular disease is very important. TIA, NICE issued updated guidelines related to stroke and TIA in 2017. They continued advocating the use of ABCD2 prognostic score for risk stratifying patients who have had a TIA. So ABCD4, age more than 60 is 1 point, blood pressure more than 140/90 1 point, clinical features like unilateral weakness, speech disturbance, no weakness. This one is 1 point and unilateral weakness is 2 points. Duration of symptoms is more than 60 minutes 2 points, 10 to 59 minutes 1 point. Patient has diabetes 1 point, so maximum work point is 7. More than 4, you start aspirin immediately. Specialist assessment and investigation within 24 hours of onset of symptoms. Measures for secondary prevention introduced as soon as the diagnosis is confirmed, including the discussion of individual risk factors. ABCD2 risk score 3 less than 3. Specialist assessment within 1 week of some symptom onset, including brain decision imaging or not. Measures for secondary prevention introduced as soon as the diagnosis is confirmed, and including discussion of individual risk factors. People with crescendo TIA, 2 or more TIAs in a week, should be treated or as being at high risk of stroke, even though they may have an ABCD2 score of 3 or below. People who have had a TIA who present late more than 1 week should be treated as though they are at lower risk of stroke. For them as well, aspirin 200 milligrams and immediately, orally if not dysphagic, rectal or enteral TB if dysphagic. Anti-circulatory TIA after a specialist assessment, if considered as candidates for carotid endarterectomy, should have carotid imaging within 1 week of onset of symptoms. Consideration depends largely on patient's fitness for surgery. Cancer dual antiplatelets for 3 weeks if ABCD score more than 4. 3 weeks. Okay. After acute phase, start clopidogrel 75 milligram for secondary prevention in addition to statin. So aspirin to start. Okay. People with AF and TIA will automatically score SHAD-VAS score more than 2. Should be considered for anticoagulation treatment: apixaban, dabigatran, rivaroxaban, or warfarin. Carotid artery endarterectomy. Recommend if patient has suffered TIA in that carotid territory and are not severely disabled. Okay, should only be considered if carotid stent is more than 70% according to ECST criteria. Okay, going to stroke now. Ischemic stroke. NICE guidelines selected points related to aquatic stroke include blood glucose, hydration, oxygen saturation, and temperature should be normalized. Swallowing should be assessed before giving any oral food, fluid, or medication within 4 hours. BP should not be lowered in the acute phase unless there are complications like hypertensive encephalopathy or nephropathy or heart failure. BP reduction to 185 by 110 or lower should be considered in people who are candidates of thrombolysis. So for thrombolysis may be indicated. Aspirin 300 mg orally. Rectal or angiotype should be given as possible. If a hemorrhagic stroke has been excluded, if patient is not for thrombolysis. As soon as possible, if it's excluded. Okay. So it's not. Let's see this again. Aspirin orally, rectally or NG should be given as soon as possible if a hemorrhagic stroke has been excluded. If patient is not for thrombolysis. Patient should be admitted to the specialist acute stroke unit. Immediate initiation of statin treatment is not recommended in people with acute stroke. However, if patient is already on statin, they should continue statin. In practice, most patients with ischemic stroke will get a statin if this last follow assessment after 24 to 48 hours. Okay, so now next is thrombolysis. Some things may have changed in the past few years. Okay. Thrombolysis should only be given if severity of stroke has been assessed using NIHS stroke scale. It is administered within 4.5 hours. Is still the same. And hemorrhage has been differently excluded. Imaging has been performed. If patient woke up from sleep with a stroke, do not thrombolyze. Even if reached in 4.5 hours, exact time of stroke is unknown. So you don't thrombolyze in a wake-up stroke. Okay. NIH, okay, it's not important. Alteplase is currently recommended by NICE for thrombolysis. 4.5 hours. Nice guidelines: prevention of further occlusive vascular event following stroke. TIA 300 milligram should be continued for 2 weeks or until hospital discharge. Thereafter, clopidogrel should be started. If there is history of dyspepsia, PPI should be given with aspirin. If clopid is not tolerated, then modified release dipyridamole can be given with aspirin. This alone only if aspirin and clopid are contraindicated. So if both are contraindicated, you can give dipyridamole. And people with disabling ischemic stroke who are in AF should be treated with aspirin for 2 weeks before starting anticoagulation. So wait for 2 weeks. After that, you can start treatment for AF. And thrombectomy. So for thrombectomy for acute stroke, there is outgoing evidence that thrombectomy is able to achieve good outcomes in acute stroke. And thrombectomy can be considered as the primary PCR of acute stroke. This area of practice is currently under investigation, so actually this has changed. Thrombectomy can be given within 6 hours window. And also if there is a wake up stroke and there is like proximal artery or anterior circulation block, you can posterior or anterior circulation, you can give thrombectomy as well. 6 hours with it, remember. If it's before 4.5 hours, you can give both thrombolysis and thrombectomy. Okay, dual platelet is indicated as initial management. High risk TIA, more the ABCD score more than 4, minor ischemic stroke less than 3, duration 3 weeks. Okay. Now moving towards an important topic, stroke by anatomy, like which portion of the brain is affected and how it's affected. So stroke by anatomy: cerebral arteries anterior. For anterior, you will see contralateral hemiparesis and contralateral hemiparesis sensory loss, lower extremity more than upper extremity. Disconnection syndrome, acanthic mute patient. So this is what you see. You know how the brain, in the anatomy of the brain, how everything is placed. So ACA, anterior stroke will affect the legs more than the arms. This is the arm, this is the legs. Okay, so contralateral hemiparesis and sensory loss, lower extremity more than upper extremity. Okay, and middle contralateral hemiparesis and sensory loss same, but upper extremity more than lower extremity, and contralateral hemianopia as well because the eyes are coming here as well, and aphasia, wernicke's, and gaze abnormalities. Posterior will be contralateral hemianopia with macular sparing, disconnection syndrome as well. Very important. Okay, lacunar stroke, when stroke involves small arteries deep within the brain, present with either isolated hemiparesis or hemisensory loss or hemiparesis with limb ataxia. Okay, lateral medulla, pica as we say. So this is the brain stem, as you can see, is midbrain and it's pons as medulla. So lateral medulla is in this lateral sides. It's supplied by posterior inferior cerebellar artery, lateral medulla, pica we say. So what happens is basically 9, 10, 11 are affected, the cranial nerves 9, 10, 11. So since it's also affecting the cerebellum, so ataxia nystagmus will be there as part of the cerebellum. Dysphagia will be there, 10th nerve, facial numbness and cranial nerve palsy. Okay, some sort of 7 is also affected, but 9, 10, 11 is mostly affected. Contralateral, this is ipsilateral, all these things. Contralateral limb sensory loss, sensory, and pontine, there is ICA, 6. Okay, horizontal gaze palsy, 7 nerve, and contralateral hemiparesis. Okay, basilar artery, CVA is typically associated with poor prognosis. Most of the patients present with nausea, vomiting, and vertigo. Some patients with motor deficits. These are 3 as speech involvement, and all headaches can be there. May present with visual disturbances. This include abducens, nerve palsy, conjugate Killis palsy, internuclear ophthalmoplegia, ocular bobbing, locked-in syndrome. Patient is awake but is unable to respond in any way except by vertical gaze and blinking. Lesion is in ventral pons. Okay. So 70% of the basal strokes are hypertensive. So because of hypertension, imagine include vigorous control of hypertension and antiplatelet agents. Okay, lateral medullary syndrome again is coming up, as we've said, it's from pica. It's lateral medulla. So it's a very common question in MRCP Part 1 and also in MRCP Part 2. It's also known as Wallenberg's syndrome. Occurs following occlusion of posterior inferior cerebral artery pica, resulting in sensory and sympathetic disturbance. What are the disturbance? So it's a favorite MRCP question, as I've said. Cerebral features are there since it's cerebral artery, ataxia and nystagmus, cerebral features. And brainstem features are ipsilateral and contralateral. It's divided into two. So first, ipsilateral will be dysphagia, facial numbness, cranial nerve palsy, like Horner's can be seen. Okay, brainstem features. And contralateral will be limb sensory loss. Commonly speaks spinothalamic tract signs like pain and temperature. So as you know, the pain and temperature tracks decussates at the level. So it's opposite, contralateral. So ipsilateral will be dysphagia, facial numbness, cranial nerve palsy, or something, all things like that. And contralateral will be sensory loss, pain and temperature. Pica must be distinguished from posterior communicative. It's not the same thing. Okay, PCA is PCA. That's pica, which is a common site for aneurysm formation that causes pain and third palsy. So that's different. Okay, Oxfordshire Community Stroke Scale. This is divided stroke into some levels here. TACS, PACS, LACS, all these things. TACS is total anterior circulatory stroke, combination of three elements, high disability chance, higher cerebral dysfunction like dysphagia and all that, low GCS, contralateral sensory or motor deficit, visual field defect. PACS will be two of the three of these. LACS will be pure lacunar stroke. It's partial. Pure motor or pure sensory syndrome, or ataxic hemiparesis or dysarthria clumsy hand syndrome. POCS, posterior circulation syndrome, high mortality chance due to brainstem involvement. So we all have experience in the wards that posterior circulation strokes are really much risky. So there will be bilateral motor or sensory deficit or disorder of the conjugate eye movement, or solitary visual field defect or cerebral dysfunction, or crossed cranial nerve and sensory motor signs. So important. Moving to hemorrhage, subarachnoid hemorrhage. 80%, 85% due to rupture of the berry aneurysm. We know that conditions associated with berry aneurysm include adult polycystic kidney disease, very much a good association. Ehlers-Danlos syndrome and coagulation of the aorta can also cause subarachnoid hemorrhage. AV malformation, trauma, tumors, all can. So investigation is CT negative in 5% and LP done after 12 hours. Allowing time for xanthochromia to develop with the CSF. If the CSF examination did not reveal xanthochromia, or there are still a high level of clinical suspicion, then cerebral angiography venography would be the next step. ECG may show widespread T inversion or ST depression, widespread inversion and depression. Okay. Complications can be rebleeding, of course, and obstructive hydrocephalus due to blood in the ventricles. Okay. Vasospasm leading to cerebral ischemia can occur. So we give him nimodipine for that. Intracranial hemorrhage can cause changes in the ECG, which are typically deep symmetrical T-wave inversion and prolonged QT as well. Management neurosurgical opinion, no clear evidence over early surgical intervention against delayed intervention. Nimodipine 60 mg for olive bipalals has shown to decrease the severity of neurological deficit but doesn't decrease rebleeding. So what it does, the way nimodipine works in subarachnoid hemorrhage is not fully understood. It has been previously postulated that it decreases cerebral vasospasm, hence maintaining the cerebral perfusion, but this has not been demonstrated in studies. So decreases vasospasm, maintains the circulation, perfusion of cerebrum. That's all it to remember. Pituitary apoplexy, one of the differentials of a headache, bad headache. So sudden enlargement of the pituitary tumor, secondary to hemorrhage or infarction. So this is already a tumor. It's sudden enlargement of it. Sudden onset headache similar to that seen in SAH, subarachnoid hemorrhage, vomiting, neck stiffness, visual field defect, classically bitemporal superior quadrantic defect, extraocular nerve pulses, features of pituitary insufficiency, hypertension secondary to hypohidrotism, erectile disturbance. Management can be IV hydrocortisone should be given to prevent Addisonian crisis. Not really, discussed matter this one. but it seems very important. Subdural hemorrhage, something which keeps on coming in the exam. Classic clue is fluctuating conscious level. So the combination of falls, alcohol excess, fluctuating episodes of confusion, and focal neurology points towards the diagnosis of subdural hemorrhage. The phrase fluctuating conscious level is common in the question and should always bring to mind subdural hemorrhage. Alcohol as well, falls, alcohol. Most commonly secondary to trauma, old person alcohol falling over. Initial injury may be minor and is often forgotten, caused by bleeding from the damaged breathing veins between cortex and the venous sinuses. Features can be headache, classically fluctuating consciousness level, raised ICP. Needs surgical review, borehole can be done if it's too much bleeding. Another question which keeps on coming in the exam is about extradural hematoma. Okay, there's extradural, there's subdural. So bleeding into the space between the dura mater and the skull. So we all know that the skull, the layers are dura mater on the outside, of course. Dura mater, then there's arachnoid matter, then there's the pia matter. So in between the pia and the arachnoid, there's subarachnoid space as well. So let's see how bleeding into the space between dura mater and the skull. So like here outside, this is extradural hematoma. So often results from the acceleration trauma or a blow to the side of the head. The majority of epidural hematomas occur in the temporal region, where skull fractures cause a rupture of the middle meningeal artery. So of course it's in the outside, can happen like temporal region is like more prone to it. And features of raised intracranial pressure. Some patients may exhibit a lucid interval, so there will be an interval where it is off and then it's coming back. So this is a very good hint in the question. It's a very good clue. Okay, subdural hematoma, bleeding into the outermost meningeal layer, most commonly occurs around the frontal and parietal lobes. Subdural is underdural, so it's here. And risk factors include old age, alcoholism. This is it's a common clue. And there's this fluctuating consciousness level clue as well. Slower onset of symptoms than an epidural hematoma. Slower onset, so epidural will be more. Epidural is extradural, same thing. Okay. Subarachnoid hemorrhage usually spontaneously in context of ruptured cerebral aneurysm, but may be associated with other injuries when a patient has sustained a traumatic brain injury. Okay. Subclavian steal syndrome is associated with retrograde flow in the vertebral artery due to proximal subclavian artery stenosis. Neurological symptoms are precipitated by vigorous exercise with the arm of the head, such as bending a wall. Okay. Diagnosis is often confused with TIA or epilepsy. Doppler ultrasound and MRI investigation or choice, the endarterectomy and stenting are common surgical methods involved in relieving the symptoms associated with this condition. Okay, that's good. Intracranial venous thrombosis is also a common thing, like stroke in the wards. So it can cause cerebral infarction, much less common than arterial cause. 50% of patients have isolated sagittal sinus thrombosis. The remainder have coexistent lateral sinus thrombosis and cavernous sinus thrombosis. So headache, features can be headache, nausea and vomiting, and papillary edema. All these things can be there. Some similar to hemorrhage. Let's see again. And cause cerebral infarction, much less common than arterial causes. So it's venous, as you know. 50% have isolated sagittal sinus thrombosis. The remainder have coexistent lateral sinus thrombosis and cavernous sinus thrombosis. This can all occur. Headache, nausea, vomiting, papillary edema. So it will be papillary edema. So cavernous sinus thrombosis, sagittal sinus thrombosis, lateral sinus thrombosis. 6th and 7th cranial nerve pulses can happen in lateral sinus thrombosis. 6th and 7th, so abducens nerve and facial nerve. Sagittal sinus thrombosis may present with seizures and hemiplegia, and parasagittal, biparietal, or bifrontal hemorrhagic infections are seen. Cavernous sinus thrombosis. Possible cause of cavernous sinus thrombosis are local infection like sinusitis, neoplasia, trauma, ophthalmoplegia due to 3rd, 4th, and 5th nerve damage. 3rd, 4th, 5th. So 3, 4, 5. ophthalmoplegia. Okay, I think it's 346. Yes. Trigeminal nerve involvement may lead to hyperesthesia of the upper face and eye pain. And central retinal vein thrombosis as well, swollen eyelids. So 3, 4, 5, 6 are really affected. See some damage and features of damage. Okay, moving towards inherited neurological disorders, like very important as well. Keeps on coming up in exams, and very important to revise all of them properly. So Friedreich's ataxia, a topic which may be a bit difficult for some. It's AR. First, you have to remember that autosomal recessive is the most common cause of early onset hereditary ataxia actually, and it's an autosomal recessive trinucleotide repeat disorder characterized by GAA repeat in the X25 gene on the chromosome. Okay, so Friedreich's ataxia is autosomal recessive trinucleotide repeat disorder characterized by GAA repeat in the X25 gene on chromosome 9. So Friedreich's ataxia, Friedreich's ataxia 9. Friedreich's ataxia is unusual among trinucleotide repeat disorder. Is in not demonstrating the phenomenon of anticipation. Okay. Typical onset is 10 to 15 years. This is something important. 10 to 15 years old guy called Frederick. Just remember that. And he's recessive. Okay. Neurological features can be absent ankle jerk and extensor plantar, something we've seen in many diseases in the neuro. And then cerebellar ataxia will be there. The name itself says ataxia. So ataxia is there. Optic atrophy is there. Okay. So this may have other features as well. Spinocerebellar tract degeneration as well. And some associations can be cardiomyopathy, hypertrophic obstructive cardiomyopathy, diabetes mellitus, high arched palate. This is something confusing with other diseases, genetic diseases. High arched palate as well, Friedreich's ataxia. So it's better to see a picture of the condition, someone who's suffering from it. That will be better. Okay, next is hereditary sensory motor neuropathy, HSMN. It's a relatively new term which encompasses Charcot-Marie disease, also known as peroneal muscular atrophy. Peroneal muscular atrophy. Over 7 types have been categorized. All types are autosomal dominant. So previously hereditary, we saw one that is dominant. This one is also dominant. 80. Except type 4, autosomal recessive, and type X, which is X-linked. 25% of cases genetic cause can be identified. Only 2 types are common in clinical practice. Okay, so only 2 types are common in clinical practice that we see. Type 1 is primarily due to demyelinating pathology. Type 2 is due to axonal pathology. So think of not in alphabetical order. 1 is D, 2 is A. So 1D, 2A. So demyelination will cause delivery problem, like velocity will decrease, and for axonal pathology there will be amplitude problem. So let's see the type 1 AD 1D due to defect in PMP22 gene, which is both for myelin, PMP peripheral myelin protein. So demyelination, as I said before, features often start at puberty. So mainly the thing is demyelination in this disease. Motor symptoms predominate as well. Distal muscle wasting, so distal muscle will be wasted. Pes cavus, as you can see, high arched foot, and claw toes can be seen. Foot drop can be seen. Left leg weakness often first features, and nerve conduction velocity is greatly decreased, less than 30 meters per second. So speed will be decreased as it's demyelinating. So PMP222 gene involved starts at puberty. Motor symptoms predominate. Distal muscle wasting, foot drop, velocity is decreased. All these things will be there, and it's also dominant type 1. Okay, the part type 2 is not really mentioned here, as it's not maybe very important clinically. Neurofibromatosis is another autosomal dominant disorder, and type 2 are 2 types are there as well. Both are inherited in autosomal dominant fashion. And NF1 is also known as Reckling-Hausen syndrome. It is caused by gene mutation in chromosome 17, which encodes neurofibromin and affects around 1 in 4,000. NF2 is caused by gene mutation on chromosome 22 and affects 1 in 1 lakh. First type is you'll see some features like cafe ole spots. Mm, this diameter, axillary or groin freckles, peripheral or neurofibromas, and iris lesion nodules with more than 90% scoliosis. Lesion nodules in the iris, you can see. And type 2 is bilateral acoustic neuroma. So NF1 chromosome 17, NF2, the word neurofibromatosis has 17 letters, so NF1 17, chromosome 22, all the 2's. So the next one is a very important and very commonly asked question: von Hippel-Lindau syndrome. It's also autosomal dominant. All the neurological inherited disorder except for Friedreich's ataxia, it looks like it's autosomal dominant. So von Hippel-Lindau retinal and cerebellar hemangiomas are key feature of this syndrome. Retinal hemangioma are bilateral, and in 25% of the patient it may lead to vitreous hemorrhage. Very important, vitreous hemorrhage. And von Hippel-Lindau syndrome is an autosomal dominant condition predisposing to neoplasia. It's due to an abnormality in the VHL gene located in stratum of chromosome 3. So what are the features you see? Okay, so cerebellar hemangioma can secrete cryothyropoietin that causes secondary polycythemia. Retinal hemangioma, vitreous hemorrhage. Renal cyst, premalignant. Pheochromocytoma, extrarenal cyst like epididymal pancreatic hepatic cyst and tumor. So all the cysts can occur, many places. Cerebellar, retinal, renal cyst, pheochromocytoma, extrarenal like epididymal pancreatic hepatic, so many. Tuberous sclerosis, another very important topic. It's a genetic condition of autosomal dominant inheritance as well. Only Friedreich's ataxia is AR, I have to say. So the majority of features are seen in our neurocutaneous. So tuberous sclerosis is mainly cutaneous, neuro and cutaneous. Depigmented ash leaf spots which fluoresce under UV light, roughened patches of skin over lumbar spine, sharp green patches, adenoma, sebaceous butterfly distribution over nose, fibromata beneath nails, subungual fibromata, cafe ole spots may be seen, but then more in neurofibromatous versus 1. Developmental delay will be there, epilepsy, intellectual impairment. Okay. Rough clumsy person holding a cigarette and a coffee with a butterfly on his nose while he's dancing. So clumsy is intellectual development, all that. Cigarette, ash, coffee, or cafe ole, but this is not really predominant. Dancing, epilepsy. Also retinal hematomas is also included. Retinal hematomas compared to von Hippel-Lindau is retinal hemangiomas. This is hematomas, dense white areas on retina. Rhabdomyoma of the heart, gliomatous change in the brain lesions, polycystic kidney, renal angiomyolipomata. It's a very common question actually, this one. Okay, spinal cord abnormalities. Firstly, syringomyelia is also a very commonly asked question for Mrcp part 1. It's a developmental slowly enlarging cavitary expansion of the cervical cord that produces progressive myelopathy. Symptoms begin insidiously in adolescence or early adulthood. Progress irregularly and may undergo spontaneous arrest for several years. Most patients acquire a cervical thoracic scoliosis. Okay. So syringomyelia basically causes spinothalamic sensory loss, pain and temperature, PT. Syringopy. So just remember syringopty. So development of syrinx within the spinal cord, it extends into the medulla, then termed syringopulpia, strongly associated with aerial malformation, and may be asymmetrical initially, slowly progressive, probably over years. Motor, wasting and weakness of arms, sensory, spinothalamic sensory loss, PT, as I said, and loss of reflexes and bilateral upgoing plantar, also seen Horner syndrome. So you can see that as well. So localization of the lesion of part 2, of course. And for this one, you can see syringomyelia, MRI of syringomyelia associated with Curie malformation, T1 shows image through cervical and upper thoracic spine, demonstrates descent of cerebellar tonsils, uh, and the worm is below the level of foramen magnum, within the substance of cervical and thoracic cord. CSF collection dilates the cervical central canal, and white arrows. At syrinx, there is anterior horn cell involvement, lower motor neuron pattern of weakness. At central decussating fibers, spinal thalamic tract dissociated sensory loss with late development of neuropathic arthropathy. Or corticospinal tract below the level of springs result in spastic paraparesis. So spastic paraparesis and development of neuropathic arthropathy, sensory loss, and low motor pattern of weakness. So MRI is the investigation of choice. Okay. Next is transverse myelitis, also important. It's an inflammatory lesion that affects the cord, usually secondary to viral changes, illness. Viral illness, okay, important part. Constitutional symptoms such as headache and fever are common as pain. Signs are indistinguishable from those caused by cord compression, and all sensory aspects are equally affected with no sparing of proprioception. So HIV, HSV, EBV all can happen. CSF mild pleocytosis and mild swelling of the cord in the affected region, MRI. 60% of patients regain full function, remaining 40% with residual problems ranging from mild bladder dysfunction to paralysis. So not much written about transverse myelitis here. Brown-Sequard syndrome is hemisection of the spinal cord. It's easier to remember like that. Very important, this spinal cord portion of the topic keeps on coming in the exams. So it's a loss of sensation and motor function, paralysis and texture that is caused by lateral hemisection of the spinal cord. So you have to know about the hemisection of the spine, like what really is there. So features will be fine ipsilateral loss of fine touch, vibration, proprioception. So as you know that ipsilateral is the dorsal column. Okay. Since dorsal column is like ipsilateral, loss will be there. Fine touch and proprioception. Okay, so dorsal column actually decussates at the medulla in the brainstem. So, if since it's below the brainstem, ipsilateral loss is there. So ipsilateral loss of fine touch, vibration, proprioception. This is the dorsal column. And ipsilateral hyperreflexia and extensor plantar reflex. Okay, and then contralateral loss of pain and temperature sensation occurs in the side. This pain and temperature, that is the spinal thalamic tract, right? Okay, spinal thalamic tract causing pain and temperature loss at the opposite side, because it's decussating at the level, so opposite will be there. So in this diagram you can see the green side is the contralateral spinal thalamic tract lesion, pain and temperature loss. The lesion is on this side, and hypotonic paresis is also there on the same side. Okay, segmental anesthesia at the level of contralateral loss of pain and temperature sensation occurs after in the side, and segmental anesthesia at the level of lesion. Complete syndrome picture is rare, but many patients may only exhibit some features. Trauma is a common cause of Brown-Sequard syndrome. So I'm coming to the main summary. Trauma is a common cause. Demyelination due to multiple sclerosis is another common cause, but any lateral cord lesion, ischemia, hemorrhage, granular tumor may give this picture. So some things you have to remember about Brown-Sequard syndrome is basically lateral hemisection of the spinal cord. If you see, this is the spinal cord, and then if you think about, this is the anterior and this is the posterior, this is the DCS, dorsal column getting affected, touch and proprioception, if this part is hampered, if you're thinking. And then there is this contralateral spinal thalamic tract. If this is hampered, then the opposite end is gone, and if this is hampered, then the same side there will be touch and proprioception gone, and happens due to trauma demyelination. And of course there will be hyperreflexia and extensor plantar reflex. Next is subacute combined degeneration of the cord, also known as Lectham's disease. Refers to degeneration of the posterior and lateral posterior, that is distal column, and the lateral columns of the spinal cord as a result of vitamin B12 deficiency. E deficiency or fatigue ataxia associated with pernicious anemia. I didn't know that. So features will be patchy loss of myelin in the dorsal columns, of course, lateral columns, and present with progressive weakness of the leg, arm, tingling and numbness. Visual and mental change may also be present. Bilateral spastic paralysis may develop, and pressure, vibration, sensation, decreased degrees of due to DCS involvement. And positive evidence may be seen. Prolonged deficiency more than 3 months may lead to irreversible nervous damage. If someone is deficient in vitamin B12 and folic acid, B12 must be treated first to avoid precipitating of SCCD. Therapy with vitamin B12 results in partial to full recovery, depending on the duration and extent of the neurodegeneration. So lateral columns are there, and posterior columns as well. So bilateral spastic paralysis will be there, okay, and may develop, and pressure, vibration, touch sensation are diminished. Remember all these things properly. Next is spinal cord compression. The spinal cord compression is a neurological emergency, and in exam and medical ward context, it's quite common in cancer patients, and affects up to 5% of cancer patients. Cancer patients, a very important clue. It's more common in patients with lung, breast, and prostate carcinoma. Lung, breast, prostate carcinoma, and features slow onset of symptoms over weeks, but can be acute as a result of trauma or metastasis. So basically, slow onset of symptoms may be there over weeks, but can be as a result of trauma or metastasis, especially if there is associated arterial occlusion. Pain, localized over the spine or in a root distribution, which may be aggravated by sneezing, coughing, or straining. And sensory paresthesia, numbness or cold sensation, especially in the lower limbs, which spread proximally, often to a level on the trunk. Motor weakness, heaviness or stiffness of the limb, most commonly the leg. Sphincter, urgency or hindrance of the micturition, especially eventually leading to urinary retention. So everything is there. Urinary retention, there's motor weakness, heaviness or stiffness, restless numbness of cold sensation. Okay. Neurological signs depend on the level of the lesion. Tendon reflexes tend to be increased below the level of the lesion and absent at the level of the lesion. Tendon reflex increase below, absent at the level. Management, urgent referral to neurosurgery, although in some places this is under orthopedics. In context of the malignancy, urgent oncological assessment for consideration of radiotherapy or surgery. High dose dexamethasone can also be used. The table demonstrates the expected features according to the level of the compression, so this is very important as well. Cervical, above C5. So above C5, what do you see? Upper motor neuron signs and sensory loss in all 4 limbs. So since it's above C5, the hands and legs are all coming. All 4 limbs, sensory loss in all 4 limbs, and upper motor neuron sign. Diaphragm weakness, phrenic nerve. C5 to T1, lower motor neuron signs and segmental sensory loss in the upper limb. What? Lower motor neuron signs in upper limb. So wrong thing. And the upper limbs, and then upper motor neuron signs in the lower limbs. Okay, respiratory and intercostal muscle weakness may be there. Okay. Thoracic cord, spastic paraplegia with sensory loss on the trunk. A weakness of leg, sacral loss of sensation, and extensor plantar response. Okay. So according to this, to find out where is the lesion, there is a spinal cord compression. Okay, so next will be cauda equina. So in cauda equina, spinal cord approximately ends at the T12L1 spinal level, and spinal lesions below this can cause lower motor neuron signs only by affecting the cauda equina. Difficulty with micturition, loss of anal sphincter, tone or fecal incontinence, saddle anesthesia, gait disturbance, and pain and numbness or weakness affecting one or both legs. Very, very important features. So micturition, difficulty, loss of anal sphincter, and fecal incontinence, saddle anesthesia, gait disturbance, and pain and numbness or weakness affecting both legs. So it's below T12L1, below the spinal level. Only lower motor neuron signs will be there. L3 nerve root compression. So L3 is important. So this one keeps on coming, sensory loss from the anterior thigh. Sensory loss, there's a picture here. Sensory loss to the anterior thigh to the medial aspect of the lower leg from here to here, L3. Weak quadriceps, decreased knee reflex, and positive femoral stretch test. Remember that. Okay. And L4, don't think about the knee. L4 is knee, L3 is the thigh, 3 is thigh, 4 is knee, 5 is foot. TKF. Okay, 3, 4, 5. TK. 3, 4, 5. TKF. Okay, so knee is aspects of the knee, as you can say, as I've said before. Weak quadriceps, as like this. Decreased knee reflex, just like that. Positive femoral. These all three are same. These two are same. Just sensory loss from the anterior thigh to the medial aspect of the lower leg. Sensory loss anterior aspect of the thigh. So knee. Sorry. So remember, L3 is thigh, and L4 is knee. Rest are same. Positive femoral stretch test, decreased knee reflex, weak quadriceps, all the same. L5 would be sensory loss in dorsum of the foot. So dorsum is this part of the foot. So it's foot. Weakness in the foot and big toe dorsiflexion. So dorsiflexion is basically this one, dorsiflexion, big toe dorsiflexion. Coming here, dorsiflexion. Okay, reflexes intact. Positive sciatic nerve stretch test. So reflex is intact. So good thing is foot is intact. So reflex foot is intact. As in reflex is intact in foot. Weakness in foot and big toe dorsiflexion. Okay. S1 nerve root compression. Sensory loss in the posterior aspect of leg and lateral aspect of foot. Lateral aspect of foot and posterior aspect of leg. Weakness in plantar flexion of foot. So plantar extensor is spans out, and this one is weakness in that. Decrease and ankle reflex, positive sciatic nerve stretch test. So only thing which is common is positive sciatic nerve stretch test. The first two is femoral stretch test. Second two is sciatic nerve stretch test. Needs to be revised every now and then. Okay? This will be very important, excellently important, extremely important. Okay, so peripheral neurological abnormalities. Well, of course, it's important as well. Okay, so peripheral neurological abnormalities. There's the demyelinating pathology, as I've said, 1D, 2A. Remember that. So there's HSMN CMT type 1, as I've said. So demyelinating problem can be caused by GBS, acute inflammatory demyelinating polyneuropathy. The name says it. CIDP, the name says it. Amiodarone, Deron, and paraprotein neuropathy. So all these, you think about it. And axonal problems, alcohol, A for alcohol, diabetes mellitus, so vasculitis, and amplitude problem, A problem, delivery problem, B12 deficiency, and type 2, as I've said. So alcohol, diabetes, vasculitis, B12 deficiency type 2, axonal pathology. And the demyelinating is, diabetic alcoholic. Just remember diabetic alcoholic vasculitic patient, axonal pathology. So nerve conduction studies are useful to determine axonal or demyelinating pathology. So I've said before, axonal amplitude, normal velocity but reduced amplitude, and decreased conduction velocity, normal amplitude. Motor versus sensory involvement, predominantly motor loss, GBS, porphyria, lead poisoning, HSMN, CIDP, diphtheria. Predominantly sensory loss can be diabetes, uremia, leprosy. The schemes can come in the exam as well. So alcoholism, vitamin B12 deficiency, diabetes, uremia, leprosy, amyloidosis, sensory loss. And motor loss can be GBS, HSMN, lead poisoning, CIDP, diphtheria, porphyria. More or less all demyelinating are here and axonal are here actually. Alcoholic neuropathy, secondary to both jet effect, toxic effect, and decreased absorption of B vitamins. Sensory symptoms typically present prior to motor symptoms. And B12 deficiency subacute common degeneration of the spinal cord, dorsal become affected prior to distal paresthesia. Drug using causing a peripheral neuropathy. So this there's a mnemonic called MANTV. So it's like isoniazid, then metronidazole, A for amiodarone, N for nitrofurantoin, T for tricyclic antidepressant, V for vanquistin. So just remember this mnemonic will be very helpful. Okay. Next is nerve conduction study, EMG. So what do you find in this one? As we know that GBS, CIDP, these are all demyelinating pathology, and then most of them are demyelinating pathology. So GBS, CIDP may be normal initially, but later will show sclerosing, slowing motor nerve conduction, partial conduction block. Botulism normal but show incremental response with rapid repetitive stimulation. Lambertian, small CMAMP with decrement in amplitude to repeated stimulation at low frequency but incremental response following sustained or repeated high frequency stimulation. Low frequency is decrement in amplitude but incremental response at high frequency. Myasthenic gravis, decrement in amplitude of CMMP to repetitive stimulation at 3 Hz. So even low stimulation will cause deterioration. Decrement in amplitude. Okay, autonomic neuropathy. Importance in ability to sweat, postural hypertension drop of 30 to 15, loss of decrease in heart rate following deep breathing, pupil dilates following adrenaline inhalation, and cause can be diabetes, GBS, MSA, Scheidegger, Parkinson's, HIV, Chagas disease, antihypertensive TCA, craniopharyngeal. Neurological classification, infections. So neurological infections, firstly comes meningitis, acute infection of the meninges present with a characteristic triad of fever, GCS low, and meningism consisting of headache, photophobia, stiffness of the neck, often accompanied by other signs of meningeal irritation like kerning sign, extension of the knee with the hip joint flexed causes spasm in the hamstring muscle, Brasilean spine, passive flexion of the neck causes flexion of the hip and knees. Meningism is not specific to the meningitis and can occur in patients with subarachnoid hemorrhage. Can occur as well. The triad is only found in 44% with acute bacterial meningitis. So causes can be viral and bacterial as well, and fungal as well. So viral, firstly, versus enterovirus, like ecovirus or Coxsackie virus, the most common cause of viral meningitis. Mostly affect children, prevalent in the UK during summer and autumn months. Spread is mainly by hand to mouth transmission. Oh wow. Herpes virus, simplex virus, and varicella zoster virus are more common in adolescents. HSV and varicella zoster adults. Confusion is a primary symptom. HSV1 encephalitis. Cold sores are there. HSV1 and meningitis is with 2 can have genital herpes. Okay. Managed symptomatically except for HSV1 where cyclovir is given. Bacterial 0.6 to 4 per 1 lakh year. Adults in developed countries. So neonates, it's basically E. coli, Proteus, Streptococcus. Preschool children is this one, and for older people, Streptococcus pneumonia and nasal meningitis. Fungal can be Cryptococcus neoformans, Candida, Histoplasma, Blastomyces. All these things can cause meningitis as well. Okay, non-infective sterile meningitis, malignancy, breast bronchial blood malignancies, and BBB. Freebies, inflammatory sarcoid SLE disease. So investigation urine bloods and inflammatory markers, LP for CSF analysis and CT brain of course. CT before LP only when GCS is less than 15. Focal neurology, like deficit is there. Recent seizure, recent neurosurgery, immunosuppressed head trauma. CSF finding in meningitis. Okay, CSF finding in meningitis. Opening pressure is 100 to 180. Normal. Cell count 0 to 5. Protein is less than 40. Glucose 2 to 4 milligram or more than 60% of blood. So in bacterial, you'll see opening pressure is higher. Similarly in TB or fungal, and also in viral, it can be also normal. In cell count, of course, in bacteria there will be neutrophils more, viral will be lymphocytes more, and strangely in TB and fungal lymphocytes more. And protein is not a very useful criteria in bacterial infection, but for viral or TB fungal is very high. So let's see, viral is like high or medium, and glucose will be severely low in bacterial. Just think about the bacteria is eating glucose and breaking down proteins. Okay, severely low, and fungal will be low, and viral is normal, almost normal. So listeria increases mononuclear cells, which may look like lymphocytes in CSF. Okay. Early viral meningitis may show increased neutrophils. Some virus may cause decreased glucose. TB may also cause increased neutrophils. So cause of lymphocytic CSF is TB, Lyme, syphilis. So many things are there. All of these can cause lymphocytic CSF. It can also occur in malignancy, and TB and Lyme. All of this can cause lymphocytic CSF. And empirical treatment of bacterial meningitis. First line is ceftriaxone, 2 gram IV twice daily, and penicillin resistant suspected or present in community first line, vancomycin or rifampicin. If penicillin resistant, age more than 50 years, and those in whom listeria infection is suspected, brainstem signs or immunosuppression, diabetic alcohol. First line is ampicillin or cotrimoxazole, listeria infection and brainstem or whatever. Severe penicillin allergy can be vancomycin chlorpheniramine can be given, dexamethasone, particularly when pneumococcal meningitis is suspected. Must be given before or at the same time of the first dose of antibiotics. Stop the dexamethasone if a non-bacterial cause is identified. Most of the time we don't see it using it. Purpuric meningococcal rash, septicemia. No LP is required. Start empiric IV antibiotics immediately, although ideally after blood cultures and plasma samples of PCR have been taken. 7% mortality in adults, 10% suffer from hearing loss, and 10% have arthritis as a complication due to immune complex deposition in joints. So complex deposition in joint can cause arthritis, and other complications: renal failure, peripheral gangrene, pericarditis. Household contact for those with more than 4 hours contact. Prophylaxis can be given, ciprofloxacin, very important. Single dose or rifampicin for 2 days. Herpes simplex and encephalitis. Okay, herpes simplex encephalitis, common topic in Mrcp. The virus characteristically affects the temporal lobes. Questions may give the result of imaging or describe temporal lobe sign like aphasia. Okay, fever. So this can give aphasia as a clue or a picture of the CT scan or MRI, like this. MRI brain showing changes in temporal lobe due to edema and hemorrhage. Herpes simplex encephalitis. So the features can be fever, headache, psychiatric symptoms, seizures, vomiting. Focal features like aphasia, and peripheral lesions. For example, cold sores have no relation to presence of HSV encephalitis, so no connection with peripheral lesion. Pathophysiology: HSV1 responsible for 95% of cases in adults, typically affects temporal lobe and inferior frontal lobe. It's a very common question in Mrcp. And CSF will show lymphocytosis, elevated protein. PCR for its SV is to be done. CT will show medial, temporal, and inferior frontal changes, petechial hemorrhage, normal in 1/3 of the patient. And MRI is better. EEG pattern: lateralized periodic discharge at 2 Hz. Go for IV acyclovir as treatment. The prognosis is dependent on whether IV acyclovir is commenced early. If treatment is started promptly, the mortality is 10 to 20%. If left untreated, the mortality approaches 80%. Next is HIV neuro complications. Generalized neurological disease, encephalitis. The complications are encephalitis, cryptococcus, PML, AIDS, and further are there as well. Generalized neurological disease, encephalitis, may be due to CMV or HIV itself, cytomegalovirus or HIV itself. HSV encephalitis, but it's relatively rare in the context of HIV. CT can show brain edema. Important. Cryptococcus, Most common fungal infection of CNS after HIV: headache, fever, malaise, nausea, vomiting, seizures, focal neurological deficit. CSF high opening pressure. India ink test positive. So India fungus. CT may show meningeal enhancement and cerebral edema. Meningeal enhancement, cerebral edema. Meningitis is typical representation, but may occasionally cause a space-occupied lesion. PML, widespread demyelination. Progressive multifocal leukoencephalopathy, widespread demyelination will be there due to infection of oligodendrocyte by human papillomavirus, JC virus. Widespread demyelination. Symptoms: subacute onset, behavioral changes, speech, motor, visual impairment. CT, single or multiple lesions, no effect, mass effect, don't usually enhance, low attenuation diffusely. MRI is better, high signal demyelinating white matter lesion are seen in advanced HIV. So the key points are low attenuation, demyelinating features, effect by JC virus. An AIDS dementia complex caused by HIV virus itself. Symptoms can be behavioral changes, motor impairment, cortical and subcortical atrophy. Okay, focal neurological lesions can be toxoplasmosis, primary CNS lymphoma, TB, very important as well. Toxoplasmosis accounts for around 50% of cerebral lesions in patients with HIV. Constitutional symptoms can be headache, drowsiness, confusion. Headache, drowsiness, and confusion. Okay, CT usually shows multiple ring enhancing lesions. Mass effect may be seen. PS is the management. Sulfadiazine pyrimethamine. Okay, primary CNS lymphoma accounts for 30% of the cerebral lesions associated with Epstein-Barr virus. Single or multiple ring enhancing. Oh, it's a single lesion, not ring enhancing. Single lesion. Tuberculosis is much less common than toxoplasmosis or primary lymphoma. CT, single enhancing lesion. So this is associated with EBV. 50%, 30%. Okay, seborrheic sclerosing pancreatitis is recognized to be the result of chronic measles infection. It's not an uncommon disease after the widespread use of measles vaccination. There is usually a history of measles very early in life, followed by 8 years of asymptomatic period. Evolves in several stages. Initially, decline in proficiency in school, followed by diffuse myoclonic jerk in association with focal and generalized seizure, and visual deterioration due to choroidal followed by pyramidal signs with due to progressive and responsiveness. Okay. So it's about measles, chronic measles infection. If vaccination is not good, then it's going to be worse. Okay, common intracranial tumors in Mrcp. Acoustic neuroma, it's related to neurofibromatosis type 2. Accounts for approximately 5% of intracranial tumors and 90% of cerebellopontine angle. AKA vestibular schwannoma. It's a benign primary intracranial tumor of the myelin-forming cells of the vestibulocochlear nerve 8. The term acoustic is a misnomer as the tumor rarely arises from the acousticocochlear division of the vestibulocochlear nerve. Loss of corneal reflex, think acoustic neuroma. It's the most important thing. Features can be predicted by the affected cranial nerves 5, 7, and 8. 5, absent corneal reflex. 7, facial palsy. 8, hearing loss, vertigo, tinnitus. Bilateral acoustic neuroma is seen in type 2 neurofibromatosis. Okay. Next is glomus jugular tumors are slow-growing, highly vascular tumors derived from the neural tissue and arising within the jugular foramen of the temporal bone. So, female to male ratio between 3 and 6 to 1. Annual incidence around 1 in 1.3 million, tends to present between 40 to 70 years old. Rare presence with deafness and pulsatile tinnitus. Rarely causes hearing loss, 4% with vertigo if extended to middle ear. Cranial nerves 9 to 11 pass through the jugular foramen and so are commonly involved. 9 to 11, they are more involved in this thing, and less commonly affected cranial nerves are 7 and 8. 7 and 8 are not much affected. Okay, and otoscopic examination may reveal a characteristic pulsatile reddish blue mass behind the tympanic membrane. So reddish blue mass behind tympanic membrane. So glomus jugular tumor. Surgical resection is treatment of choice. Embolization and radiotherapy may have been used as well. So it's the end of neuromedicine, but then again there are some things which need to be clarified. Okay. I think toxoplasmosis. Or CNS lymphoma. Okay, so one important thing to remember here is in CNS lymphoma there will be a single homogeneous lesion, and also there will be thallium spec positive. For toxoplasmosis there will be thallium spec negative. This is how you differentiate between the two.